Hope you hear me well. So today talk will be on chest X-ray fundamentals, which will be the basic knowledge to learn about chest X-ray for the medical professionals. So in this talk, I would like to include types and techniques used in chest X-ray, quality assessment, and normal versus abnormalities detected in the chest X-rays, and how to approach a chest X-ray in a medical setup, and how to identify the lines and tubes. So the types, the first one and the commoner one is the posterior-anterior, which we are using all over. So this is the image of a normal posterior-anterior chest X-ray. This one is AP, or otherwise known as supine or frontal X-ray. We can compare this posterior-anterior with the anteroposterior. When we compare this, you can see clearly the clavicles, both clavicles has gone up, and we couldn't see the apices very clearly in anteroposterior X-rays. So that's the lack, and the expiratory effort will be less in AP. So it's difficult for a clinician to assess the entire pathology from this AP X-ray. Second one is the lateral. This is an additional X-ray we are using with the PA. In case of any masses or suspected lesions, we are doing to the lateral. Other thing is the apical or lordotic. This is a specialized X-ray where we can, if you want to see the apices more clearly, lung apices, we can do the apical or lordotic view, where the clavicles, both clavicles, you can see it's gone far more beyond the thoracic cavity, and even from the first rib we can see very clearly in the apical or lordotic view. Oblique one, of course, everyone knows this is used to assess the rib fractures. We can do the right leg oblique or the left oblique. Right oblique, here we can see the ribs very nicely rather than the left side, right? And the decubitus position if there is any suspicious of subtle pneumothorax. So the technique here is this is most likely to be involved with the radiography, but I would like to go through the basic things. So in a PA X-ray, the patient is standing like this, and the X-ray tube is on the back side of the patient. So the X-ray rays are coming from posterior to anterior, and this is the detector we are using to film the image. So this is X-ray is coming from posterior anterior. So this is the PA X-ray technique. AP can be done in different position. If it is a patient couldn't ambulate, so we can do it in supine, where the X-ray tube is positioned here and the detector will be under the bed. Same AP position in seated position, where the X-ray tube is lower down and the detector is at the back side of the patient. And the lateral view, patient will be advised to raise the arms above the neck level, so we can see the axillary area and the whole lateral chest wall. And this is the lordotic view. As I mentioned earlier, if you want to see the apices, patient was tilted backside, and the apices can be visualized clearly in this technique. And this is the decubitus position where the beam is sent through horizontal line. And again, this is the oblique view. Patient is slightly positioned in oblique manner. So if you come to the quality, next one is the quality. Before reading a X-ray, it is important to assess the quality of the X-ray. So if the quality is not adequate, we can miss the one thing. We can miss the pathology. One thing, we can give misdiagnosis to the patient. So that's why it's very important to assess the quality. For assessing the quality, we can go through a simple mnemonic called RIP, which include rotation, inspiration, and penetration. So we can discuss this separately. So this is the quality assessment. So there are two X-rays here. In the right hand side, there's the X-ray which we couldn't see the four corners clearly. For the first X-ray, the costophrenic angle is obscured, the lateral chest wall is not included, APCs are not clear, so the quality of the X-ray is not adequate. It's technically suboptimal study. So we can ask for this to repeat the X-ray. So it is corrected in the second X-ray where you can see the apex very clearly, lateral chest wall and the scapula is seen, and the costophrenic angles are nicely demonstrated. So as I mentioned, the rotation for the quality check, the first thing we are seeing is whether there is any rotation in the image or not. What is rotation? So if the image is well centered or in a midline position only, we can read it properly. So how we can assess this rotation? If you see in the second image, the spinous process are in the midline, right? That white small dot-like areas, so that is in the midline, and the clavicles that is indicated with green lines are the clavicles. So the medial end of the clavicles should be in equidistance. That is, the yellow and the medial end of the green lines should be equal in distance. Then only it will be a centered film or without rotation. So what will happen if there is a rotation? So sometimes if we position the patient may turn to other side, or patient couldn't stand in a proper position. So we can only take in a rotated image, especially in ICU setup. So here you can see the clavicles are rotated. There is no equidistance from the spinous process. So they are deviated, and due to that, you can see in the second image, the costophrenic angle is blunted. So it can give the misdiagnosis as pleural effusion or any pleural related mass or consolidation. So it won't be sharp as this if it is rotated. Second one, we have to check for the inspiration, whether the patient has taken adequate inspiration, whether the inspiratory effect is adequate. So first image, it's taken in a expiratory phase, and second one is in the full inspiration. You can see the difference very clearly. The lungs, both lungs fields are black, that is well aerated. But in the initial image, first image, the lungs are vaguely seen. There's a total haziness, and they're suspicious of whether there is a reticulation or whether there is a consolidation in the lung basis. So this can be overcome by taking the X-ray in a full inspiratory phase. So as I mentioned earlier, other disadvantage of taking in expiration is the scapula won't deviate to the lateral part. So again we can't, it will obscure the lung parenchyma, uh, that will lead to the misdiagnosis. And the cardiothoracic ratio also will significantly alter with inspiration and expiration. If it is taken in expiration, we can it will give the effect like cardiomegaly. So this is an inspiratory film where the heart is less than the 50% of the thoracic diameter here. If it is in an expiratory phase, it would be more than 50%. That will mimic a cardiomegaly, early or mild cardiomegaly. The third quality assessment is the penetration. Why penetration is important? What is penetration? So here you can see the whole vertebra through the cardiac contour in this image, right? It's nicely seen, not very clearly, but we can see it vaguely, right? But in the second image, due to over exposure, that means we are using more kilowatts to expose this film. That's why we can't see the vertebral column in this image. So what would be the disadvantage? If there is any lytic lesions in that area, any retrocardiac masses, so easily can be missed. So in that case, ask them to repeat the X-ray. So we should be able to see the vertebra up to T4 level in very clearly in the upper thorax and vaguely below that. So that is the quality check we have to go through. And the artifacts. So when we are exposing the patient for chest X-ray, we ask them to come with proper attire, like removing the jewels, removing the hair clips, uh, any implants should be removed to eliminate the artifacts. But sometimes it can happen, right? So here you can see in the first image, there's some shadow over the right shoulder area or the apices, and it extends into the lung. So this can be mimicked as a mass, any soft tissue area, soft tissue mass or sarcoma. So that is the suspicious. So here the hair, due to the unfolding of the hair, it's fold over the right shoulder and it mimic as a mass. We can repeat the X-ray, or if the hair is extend below beyond the film, then we can guess it's due to the hair, not due to the mass, right? So eliminating the artifacts also a quality check. So this is the, I have discussed something about the PA X-rays. So this is the lateral X-ray. So most of the time we are learning the how to read a PA, posterior anterior X-rays only. How to read a lateral X-ray is, in a lateral X-ray, the cardiac contour is colored as green, and above area we call it as retrosternal area, and here below behind the heart we call it as retrocardiac area. So the retrosternal and the retrocardiac area are equal in size, and the density should be equal as well. And furthermore, when you see a lateral chest X-ray, from the cranial to caudal region, the density or the darkness should increase progressively. What's the reason for that? The reason for it is aeration, or the air within the lower lungs is more. So when we inspire, we are getting more air within the lower lungs.